Hi, everyone. Thank you for joining today's web interface support call for ACOs, groups, and virtual groups. During this session, CMS will highlight important information and updates on reporting quality data through the CMS Web Interface for the 2021 performance period. This presentation will be followed by a Q&A session where attendees will have an opportunity to ask questions via the phone and support call questions box, and CMS subject matter experts will address as many questions as time allows. You are welcome to submit questions during the presentation or wait to submit your questions until the Q&A portion of the call. Now I will turn it over to Lisa Marie Gomez at CMS to begin.
Welcome everyone, and thank you for joining us today as groups, virtual groups, and APM entities prepare for CMS Web Interface quality reporting. I'm Lisa Marie Gomez with CMS, a subject matter expert on the CMS Web Interface. Joining me on the call today are other experts who will share helpful information regarding quality data reporting to the CMS Web Interface and will answer your questions during the question and answer session after today's presentation. Today's call will focus on 2021 quality reporting. You can contact the Quality Payment Program Service Center with any of your questions regarding cost, promoting interoperability, improvement activities, MIPS, or quality reporting in general. Next slide, please. This is a disclaimer slide about this presentation. Information in this presentation is current at the time of its publication, but we encourage you to please be sure that you're using the source documents and links that are provided throughout this presentation. Please stay tuned to any communication from the Quality Payment Program or Shared Savings Program regarding any updated information. Next slide, please. Now I'm going to provide a few announcements and reminders over the next few slides. Next slide, please. The CMS Web Interface will close promptly at 8 p.m. Eastern Time on March 31st, 2022. Your submission will be automatically accepted at the close of submission. As a reminder, the CMS Web Interface is accessible using the sign-in link on the Quality Payment Program website, as shown on this slide. Next slide, please. The next transition webinar for the sunsetting of the CMS Web Interface for groups and virtual groups will be held on Wednesday, February 16th, 2022, which is next week. The transition webinar are intended for groups and virtual groups. However, APM entities such as ACOs may attend to learn more about transitioning to an alternative option for quality data collection and submission. The next support call will be held on Wednesday, February 23rd, 2022, from 1 to 2:30 p.m. Eastern Time. Topics will include frequently asked measure questions regarding the following topics: Prev 6, colorectal cancer screening; Prev 10, preventative care and screening, tobacco use screening and cessation intervention; Prev 13, stent therapy for the prevention and treatment of cardiovascular disease. There may be additional topics that we add to this support call prior to the actual support call. Next slide, please. There are 3 new CMS Web Interface transition guides that are now available on the QPP resource library. Links to these documents will be shared in the chat box later on in the presentation. Next slide, please. The 2021 CMS Web Interface API is available all year for testing in the developer preview environment. Please review the links listed on this slide for more information. Next slide, please. The information on this slide is a reminder that requesting another CMS approved reason should be reserved for circumstances that are unique, unusual, and not covered by any of the denominator exclusions or exceptions in the measure specifications. Please submit your request for another CMS approved reason as soon as possible. Now I'm going to turn the presentation over to Laura Hasey, who will discuss the use of NA within the Excel template. During the last support call, there were several questions regarding this item, so we want to ensure that everyone understands the use of NA within the Excel template. Laura?
Thanks, Lisa Marie. Next slide, please. As Lisa Marie mentioned, there were some questions regarding the use of NA in the Excel template, and I will go through that. Please, next slide. So NA is a drop-down option in the Excel template, which will overwrite the data with a blank value once you upload your file. This is how users using the Excel template can delete data from the CMS Web Interface system. NA is not an option within the measure specifications. This is strictly due to an Excel template way to delete data from the web interface. Next slide, please. I will hand it over to Angie from PIMS for frequently asked measure questions.
Hi, thanks very much. This is Angie, and our first question, frequently asked questions today are for the DM2 diabetes, hemoglobin, A1C, or control greater than 9% measure. The intent of the measure is patients 18 to 75 years of age with diabetes who had a hemoglobin greater than 9% during the measurement period. For this measure, a lower performance rate indicates better performance control. Documentation of the most recent HbA1c result may be completed during a telehealth encounter. Next slide, please. Okay, question 1. For the 2021 DM2 CMS Web Interface measure, will patients only be included in the measure if they have a diagnosis of diabetes during the measurement year? Or will they be included if they have a prior diagnosis, but no diagnosis in the measurement year? So in the measure specifications, history refers to the year before the measurement period. Active diagnosis refers to the measurement period for the 21 performance period. So you would need to confirm the diagnosis of diabetes, that it's documented in the medical record in 2020 or in 2021. Question 2, for DM2, do I use the date the blood was drawn or the date of the lab results? It's appropriate to use the following priority ranking for the numerator. This is included in the numerator guidance in the measure specification. So the first option is the lab report draw date, then the lab report date, the flow sheet documentation, practitioner notes, and then other documentation. Question 3. Will HbA1c values from any setting be acceptable for the numerator for 2021 reporting? Yes, the measure does not limit the HbA1c to a specific setting. Next slide, please. Question 4, is an HbA1c reported during a telehealth visit acceptable? Yes, documentation of the most recent HbA1c result may be completed during a telehealth encounter. Question 5, are continuous glucose monitoring system results acceptable for the numerator for 2021? The answer is no. The DM2 measure for 2021 does not include CGM or continuous glucose monitoring results. Rather, it's patient-reported or from the clinician. There must be medical record documentation of a distinct HbA1c value and the date the blood was drawn. Question 6, some patients have a home HbA1c testing kit, meaning they're checking their lab values at home. Will this be allowed for 2021 for DM2? Answer is yes, patient-reported HbA1c values are allowed as long as the date and the most recent value are documented in the medical record, and this is for 2021. Next slide, please. The next section is regarding the HTN2 controlling high blood pressure measure. The intent of the measure is patients 18 to 85 who had a diagnosis of essential hypertension starting before and continuing into or starting during the first 6 months of the measurement period, and whose most recent blood pressure was adequately controlled during the measurement period. A blood pressure reading may be taken by a clinician, a remote monitoring device, and conveyed by the patient to their clinician during a telehealth encounter. Next slide, please. Okay, question 1. Are home blood pressure monitors, such as arm monitors, wrist monitors, Apple Watches, considered remote monitoring devices? So the answer is the measure specifications and guidance don't define what constitutes a remote monitoring device. They also don't define methods of conveying the blood pressure from a remote monitoring device to the clinician. So we are unable to provide guidance on specific devices or a specific workflow on how the clinician interacts with the patient using a remote monitoring device during a telehealth encounter. So the result of that then is that it's at the clinician's discretion to determine whether the remote monitoring device used to obtain the blood pressure is considered acceptable and reliable. Question 2. When we see both an inclusionary diagnosis and an exclusionary diagnosis, should the patient be in the denominator? And the answer to that would be no. In the instance a patient meets the intent of the denominator exclusion, then it is appropriate to remove that patient from the denominator. And a reminder that it is the responsibility of the group, virtual group, or ATM entity to work with the clinician to determine whether there's sufficient medical record documentation to confirm the patient's diagnosis. When submitting data through the CMS Web Interface, the expectation is that medical record documentation, in addition to coding, is available. It supports the action reported in the CMS Web Interface. Next slide, please. Okay, the next section is regarding the PREV-7 preventative care and screening influenza immunization measure. The intent of the PREV-7 measure is for patients aged 6 months and older who are seen for a visit between October 1st and March 31st to receive an influenza immunization or report previous receipt of an influenza immunization. The report of previous receipt for an influenza immunization during the flu season may be completed during a telehealth encounter. The influenza immunization itself can't be completed during a telehealth encounter. Next slide, please. Okay, question 1. Our states have an immunization registry. Can this be used as an exclusion of the medical record to qualify for the 2021 CMS Web Interface PREV-7 measure? The answer is any available medical record documentation, including immunization registry data, can be used to confirm the quality action. Question 2. The numerator guidance states the influenza immunizations during the flu season or the patient reporting previous receipt of the immunization may or may not be completed during a telehealth encounter. What does may or may not mean? And I think we covered that on the previous slide, that the immunization itself can't be done during a telehealth encounter, but a screening where the patient may report previous receipt of the immunization, where they received the immunization from August through March, can be and meets the intent of the measure. Next slide, please. Question 3, is a documented history of an egg allergy sufficient documentation to use the denominator exception for a medical reason? The answer is no. A documented history of the egg allergy in the patient's medical record alone doesn't meet the intent of the exception for the 2021 performance period. Documentation of an egg allergy must be during the measurement period and support that the allergy is still active during the appropriate time frame, which is August 2020 through March 2021, or the flu season being reported to qualify as a denominator exception. Question 4. What are the documentation timing requirements for the 2021 PREV7 measure? The medical record should support that the patient refusal, exception, or receipt of the immunization occurred during the appropriate time, which is August 2020 through March 2021 for the 2021 reporting year. PREV7 documentation should be during the measurement period and be specific to the flu season being reported. As long as the medical record documentation supports that the quality action or exception submitted is relevant to the flu season being measured, it is acceptable. And now I'll turn it back over to Lisa Marie Gomez with CMS. Thank you.
Thank you, Angie. Next slide, please. So these next few slides, we will outline the available CMS Web Interface resources. Next slide, please. Please note that the 2021 CMS Web Interface resources are available on the Quality Payment Program Resource Library. Links to these resources are now going to be provided in the chat box. We encourage you to review these resources if you have questions regarding quality requirements and measures. We'll continue to communicate any future postings and upcoming support calls. Additionally, the help and support page on the QPP website contains links to materials such as videos, webinars, and online courses, as well as other items to help with reporting and development. Next slide, please. This slide contains links to resources available for the Shared Savings Program. We encourage ACOs to review the materials available within these links for more information. Next slide, please. If you need additional assistance, please refer to the contact information listed on this slide, which pertains to the Quality Payment Program, Service Center, and the Shared Savings Program. Next slide, please. Now, just before we begin the question and answer portion of this support call, if you're interested in providing feedback and collaborating with CMS on the Quality Payment Program, we encourage you to participate in our human-centered design efforts. To get involved, please email your name, title, topic of interest, and organization to qpp.userresearch@cms.hhs.gov. Now I'm going to turn this portion of the support call over to Emily Schutz to begin the question and answer session. Emily?
Thanks, Lisa Marie. We're now going to start the Q&A portion of this webinar. You can ask questions via the Q&A box or through the webinar audio. To ask a question through the webinar audio, please raise your hand and we will unmute your line so that you can speak. To submit a question anonymously through the Q&A box, please click Send Anonymously. Otherwise, all attendees will be able to view your questions. So now we can get started. I'm going to get started with some questions that have come in throughout the presentation into the Q&A box. And the first question is about PREV13. And this question asks, are EMR records LDLs without information to specify if they are fasting or direct laboratory result type of LDL? Does CMS specify if there are certain types of LDL results or tests that would not or should be excluded?
Hi, this is Katie from the PIMS team. So in this case, we would direct you to refer to the PREV13 coding document as well as the measure specification to determine if the medical record documentation supports including the patient in the denominator. So we just refer you back to those documents to see the specific coding for denominator eligibility. And then if you have further questions, you can always reach out to us at qpp@cms.hhs.gov. Thank you.
Thanks, Katie. Our next question says, Our ACO has claims-based information in our portal that shows the claim number, date of the procedure or document, and where the claim is coming from. Would this claims information that is used be compliant, or would we need to back up documentation for the claims information?
So in this scenario, claims data can't be used to confirm a diagnosis used for sampling purposes, since claims are the original source of the diagnosis. For diagnosis sampling, claims data can be used to assist in locating the medical record documentation, but supporting medical record documentation will be required to substantiate the information reported. You may use any medical record documentation available as long as you can confirm the patient has an appropriate diagnosis as required by the measure. Thank you.
Great, thanks, Katie. We have one more question from the chat box that says, for PREV-12, when utilizing the PHQ-9 as the screener, is a score less than 5 considered negative or a score of 9 or less? Wondering is in MH1, an index PHQ-9 score of 10 or greater is needed, but only a score less than 5 on follow-up is considered remission.
So in these two measures are different in how the depression screening is treated and the requirements for medical record documentation. So PREV-12 requires that clinician's interpretation of negative or positive. The numeric value of the screening isn't required or really accepted for the measure. It's truly the clinician's interpretation based on the results of the screening and the interaction with the patient. So MH1 does require those specific scores, and those should be utilized for purposes of that measure. Thank you.
Great, thank you, Katie. We have another question that's come in through the Q&A box that asked, can we accept a patient's blood pressure reading result that was taken on a home blood pressure machine during a telehealth visit? The blood pressure equipment doesn't electronically transfer the data. The provider or clinical staff documents the results that the patient gave onto the chart.
Hi, this is Carol with the PIMS team. This was also reviewed on the slides just a few minutes ago, but for 2021, telehealth is included. A blood pressure taken by either a clinician or a remote monitoring device, their home device, or a device brought by a visiting nurse or a caregiver and conveyed by the nurse or caregiver or by the patient to the clinician is acceptable for the numerator, as long as it is the most recent blood pressure reading documented in the medical record for the patient during the measurement period. Thanks.
Great, thank you. So our next question through the Q&A box asked, we located a patient on palliative services with the code Z51.5, and the documentation discusses pain medication education. Can that qualify the patient to be removed from sampling under the hospice specification?
Hi, excuse me. So the in-hospice, it would be considered not qualified for sample. So in-hospice reason would cover instances where the patient is receiving palliative goals or comfort care. So as long as you have medical record documentation to support the patient was receiving palliative care during the measurement period, it would be appropriate to select not qualified for sample. Thank you.
Great, thanks so much. And we have one more question from the Q&A box that we can go through. And that question asks, how do we report if we have a patient that was screened for PREV-12 with PHQ-9 and scored an 8, but was not documented with negative or positive? The reporting options are, is the patient qualified for the measure, which we have yes. Then it asks, was the patient screened for depression using age-appropriate screening? And yes, we use the PHQ-9. And then the next question, was the screen positive for depression? here's the confusion because we do not have documentation saying positive or negative. So do we mark no here to the question, or do we mark no to question 2?
So in the instance where the clinician has completed a depression screening for PREV-12, but there's no documentation of negative or positive, you would report that the patient was not screened. The way that the measure flow is set up requires the screening, and then it goes on to ask if the results were negative or positive. Since you don't have the results of negative or positive, it would be treated as though the screening wasn't completed in that scenario. Thank you.
Great, thank you for that clarification. We're now going to answer some questions that have come in through the audio line. So first, I'm going to unmute your line. Karina, Magazine, or Ruben, I see that your hand is raised, so I'll let you ask your question.
Yeah, hi. So I got a question. A couple offices that I've kind of just touched base with on MH1, they had just started seeing the patient that has major depression in 2021. So they don't have that time frame to go back to that November the 1st to October the 31st of 2020 in order to make sure that the diagnosis was active at that time. And they did not have a depression screening because, you know, they didn't start seeing the patient until 2021. Would we say that this is a numerator exclusion for this patient, or do we just have to take it as a denial that we don't have the information?
Hi, this is Angie from TIMS. Okay, first of all, the patient would have to meet the denominator. So if you go through the denominator confirmation steps in the measure specifications, they have to have the active diagnosis of major depression or decided during the time period of November 1st, 2019 to October 30th, 2020. So if they don't, they also have to have one or more PHQ-9 or PHQ-9Ms during that same period. So if they don't have those things, they're not eligible for the denominator. And okay. They would, you can select not confirmed, I believe it is, when those questions are asked, or yeah.
Okay.
You may be able to confirm that. I don't know if you can, if you can't confirm the diagnosis, the first step is that you would pick not confirmed diagnosis. Then that patient will be skipped from that measure and replaced with another if one's available. Does that make sense?
Yeah, I guess my confusion is usually I guess I look at it as if you have major depression, you usually are always going to have it for the most part. So I can see that they're diagnosed with that in 2021. But since they weren't seen prior to 2021 at this particular practice, I can't say it was active back then. So I could just say I could use that no diagnosis qualifying then. That's correct?
Correct.
Okay, perfect. I just wanted to make sure I was doing that correctly. Thank you.
You're welcome.
Great, thank you so much for that question. We're going to take another question from the phone line now. So Thomasina Green, I see that your hand is raised, and I'm going to go ahead and unmute your line. And Thomasina, you will have to unmute on your end as well to be able to speak. So it looks like we might be having some audio issues. So we're going to move on to the next attendee with their hand raised. So Ashley Weger, I see that your hand is raised. So I'm going to go ahead and unmute your line.
Hi, thank you. So my question is, we have a couple of patients that were on hospice or palliative care last year, but the records wasn't ever sent to our PCP. We've had the claims. So my question is, can we request the records from last year from hospice or palliative care and upload it into the medical record to remove them from the qualification for sampling?
Hi, this is Katie from the PIMS team. We are actually going to recommend you submit that question to the service center at qpp@cms.hhs.gov, and then that way we can give you the best answer there. Thank you.
Okay, thank you.
Great, thanks so much. So moving down the line, Sandra Stewart, I see that your hand is raised, so I'm going to go ahead and unmute your line so you can ask your question. And it looks like you are self-muted as well, so you will need to unmute on your end in order to be able to speak.
I'm all set, thank you.
Oh, great, thanks so much, Sandra. Then we can move on down to our next person with their hand raised. So Prathima Pichera, I see that your hand is raised, so I'll go ahead and unmute your line.
Hey, can you hear me?
Yes, we can.
Yes, thank you. So for flu vaccine measure, can the reason flu vaccine not given this visit, immunization not offered in the clinic be used as a system reason for denomination?
This is Deb from the PIMS team. For Prev 7, the system reason should be indicated only for those cases of disruption or shortage of influenza vaccine supply. Thank you.
Okay, thank you.
Great, thanks so much for that question. And we'll move on to our next person with their hand raised. So Brett Slazeski, I'll go ahead and unmute your line so that you can speak. And you may have to unmute on your end as well. We are having a little trouble hearing you, Brett. Okay, we might have you having some technical difficulties there. So we're now going to move back to answering some questions that have come in through our Q&A box. So the first question in the Q&A box asks, in the measure guidance, it states, don't use blood pressure reported by the member, but the FAQ states this differently. Can we accept a patient's blood pressure reading result that was taken on a home blood pressure machine during a telehealth visit? The blood pressure equipment doesn't electronically transfer the data. The provider or clinical staff documents the result that the patient gives them into the chart. And I believe we may have already responded to this question. So if we have, I can go ahead and move on to the next one in the chat.
Yes, we have. Thank you.
Great. I will move on to our next question. And this question asks, where can we get a list of other CMS approved reasons?
Hi, this is Katie from the PIMS team. So there's not necessarily a list of other CMS approved reasons. Those requests are reserved for situations that are unique or unusual or not covered within the measure specification. So if you have a patient that for some reason their situation requires you to skip them, you can certainly submit that through the CMS Web Interface, and it will be reviewed and a decision will be issued. There's no guarantee that certain types of questions or cases will be approved. We do ask that you provide as much information as possible in those requests. That just helps them to be processed a little bit faster if we have as much detail up front. If, for instance, there's a certain condition the patient has that makes it unable to complete a measure on them, something along those lines, we would need specific details on their condition or diagnosis and whether there was any attempt made to complete the quality action in question. So just providing as much as possible is helpful in issuing a decision. Thank you.
Great, thank you. So our next question from our Q&A box asks, for MH1, if multiple PHQ-9s are completed, which one would be the correct one to submit? The first one completed in the time frame or any one that is less than 9. For instance, the first one in the measurement period is greater than 9 or less than 9, I apologize, and the one 6 months later is 10. Which one should we submit?
Hi, this is Angie from PIMS. So when you are confirming the denominator for MH1, you're going to look and see if the patient had a PHQ-9 or PHQ-9M score greater than 9 during the period of November 1st, 2019 through October 31st, 2020. So let's say we know you have more than one. So then you're going to enter the first instance of the PHQ-9 greater than 9. That's also associated with the diagnosis of major depression or dysthymia during that time period. And that's going to mark, that's going to be the index event date for that patient. And then that will start their measure assessment period. So you have to have one greater than 9 in order to confirm the denominator. Thanks very much.
Great, thank you. So our next question asks, do we have clarification on the CBP from the last call, whether we can use a specialist consult note for the blood pressure or if it only our ACO providers?
Hi, I'm sorry. Hi, this is Carol. Please use the most recent blood pressure. Sorry, that is not where I am. So for this one, any specialist or any physician or clinician can assess for blood pressure for this measure. Sorry, thank you.
Great, thank you. And I think we have one more question for you. This is regarding HTN2, and the question asks, should blood pressure readings from the immediate or urgent care setting be used for this metric?
So for this measure, a blood pressure value that is obtained during an inpatient or an emergency visit is restricted. Urgent care coding is present within the encounter codes tab, and therefore the urgent care visits and encounters should be used using the most recent value documented at that visit.
Great, thanks so much for that response. Our next question that has come in asks, for PREV12, if a patient is screened using a PHQ-2 and the score was 0, would that count as a negative screen if the provider moved on to a PHQ-9 and the score was 2 and they did not specify if the screen was plus or minus?
Hi, this is Katie. So the measure specifications do require that you use the most recent depression screening during the measurement period. So if there's documentation that a PHQ-9 was completed, but there's no interpretation of negative or positive, it would then be treated as though the screening wasn't performed. Thank you.
Great, thank you for that response. We have another question that asks, do home blood pressures relayed on telehealth have to have been taken on the date of the visit, or can a home blood pressure be called in and documented on a date subsequent to the visit?
So again, use the most recent documented blood pressure within the measurement period. Since the measure guidance and specifications do not define what constitutes a method of conveying the blood pressure from a remote monitoring device to the clinician, we're really unable to provide guidance on the specific workflow on how the clinician interacts with the patient during those encounters. It is up to the clinician's discretion as to whether the device used to obtain the blood pressure is considered acceptable and reliable. Medical record documentation would just need to support that the quality action was reported. So you just use the most recent blood pressure that you find documented. Thank you.
Great. Thanks so much for that response. Moving on to our next question, I asked, for tobacco screening, patients who are identified as non-smoker are considered as skipped. Are they factored into the scoring or factored into the non-consecutive ranked patients?
Hi, this is Jamie. I just want to confirm that if you screen your patient and identify them as non-smokers, you're actually meeting the intent of the very first rate, and you would meet performance for that particular rate. And I'll just move down. The second rate would be for those patients that are identified as tobacco users, and then you would do cessation. So a non-smoker would not be denominator eligible for the second rate of that particular measure for Prep 10. And then you would find that your non-smoker would also be included within performance met for the third rate, which is a combination of those screened for tobacco and those that were identified as tobacco users were provided tobacco cessation. So I hope I responded to your question, and I hope that met the expectation of what you're trying to get to. I did leave in the chat information for Service Center if you do still need a little more assistance, but hopefully that covered it. Thanks.
Great, thanks so much. And our next question asks about Prev 12. What about PHQ-9s on patients who still live at home but have advanced dementia or vascular dementia?
Hi, this is Katie again. So there's no denominator exclusion for dementia for Prev 12. It could potentially fit under a denominator exception if there's medical record documentation that the patient wasn't screened due to their diagnosis or conditions, which would fall under situations where the patient's cognitive capacity, functional capacity, or motivation to improve may impact the accuracy of results of the standardized assessment tools. So just to reiterate, there's no denominator exclusion. In order to report the denominator exception, you would have to have documentation that the patient wasn't screened due to their diagnosis or condition. Thank you.
Great, thanks so much. So now we're going to move back and answer a couple of questions that have come in through the audio line. So first, I see that Rebecca Bond, you have your hand raised, so I'm going to go ahead and unmute your line so that you can ask your question.
Thank you. So Prev 12, our clinics have a standard that PHQ-2 is positive if it's greater or equal to 3, and PHQ-9 is positive if it's greater or equal to 5. So can we just use this standard if the physician is not saying specifically they are positive or negative in the screen, because that's our standard with the clinics?
Hi, this is Katie. So the measure specification does require that documentation of whether the patient screening was negative or positive. So if you take a look at page 11 under the numerator guidance, it does state that the measure doesn't require documentation of a specific score, just whether the results of the normalized and validated depression screening tool used are considered negative or positive. So although each standardized screening tool provides guidance on whether the particular score is considered negative or positive, that clinician's interpretation would also need to be documented. And this kind of branches into, that clinician's interaction with the patient, whether screening itself is positive or negative. There's also that interaction with the patient that may influence whether the clinician documents they do or do not have, or they are, positive or negative for depression. So just going back to the measure specs do require that interpretation, not just documentation of a score.
Okay, and I do have another one that is regarding MH1. Am I okay to ask that as well?
Sure, go ahead.
Okay, so if I have a patient who has as a denominator exception code that's like outside of the 2019, but it gets brought into one of the codes later on, am I still going to accept that code? Because it was like, say, 2018 or 2017, and somebody decided to bring it in to the problem list.
Hi, this is Angie from PIMS. Are you asking about denominator exclusion code?
Yes.
Exclusion diagnosis? Yeah.
So,
right. So the denominator exclusion code can be any time prior to the measure assessment period. And I think, let's see here. Yeah, anytime prior to the end of the measure assessment period. So the measure assessment period is different for each patient. So first of all, we know that the patients in the denominator, have the diagnosis of depression, have the PHQ-9s, all of that during that time period from November 1st of 2019 through October 31st of 2020. So in order to be excluded, they could have documentation anytime prior to the measure assessment period, which is yet different. So the measure assessment period starts on the patient's index date, which will be during that 2019 and 2020. So if you have a diagnosis that is a exclusion diagnosis, prior to the patient's index event date, if you will, then it could be excluded. The patient could be excluded. It gets a little crazy because everything has to be in the denominator. They have to have all those things first during November 2019 through October 2020. But to look for exclusions, they're saying that it has to be anytime prior to the patient's measure assessment period. So then you have to figure the patient's measure assessment period, which starts on the index date. So if it's prior to the period of time, then yes, it could be used for an exclusion. And team, correct me if I'm wrong, but
so if it's in 2016 and that's the only documentation that of it as a history of depression in 2016, can we use it when it's 2019 to 2020? Asking.
I'm sorry, I'm having a little trouble hearing you. So are you asking about a depression diagnosis to put them in the denominator, or are you asking about maybe, bipolar or other personality disorders, which are denominator exclusions?
So like a bipolar or other denominator exclusion codes.
Okay.
So only have that.
So the measure specifications, you can find this on page 10 under denominator exclusions.
Okay.
So if there was an active diagnosis of any of the denominator exclusion diagnoses anytime prior to the end of that patient's measure assessment period, then they can be excluded.
Okay, but it doesn't have to be specifically during that measurement period, just prior to it.
Yes, anytime prior to that would be a eligible denominator exclusion prior to the end of that. So, you know, you've got your index event date, you've got the 12 months plus or minus 60 days, 14 months, that would be the end of the period. So if it's before their index event date, the denominator exclusion diagnosis, then you can exclude them.
Okay, okay, thank you.
You're welcome.
Great, thanks so much for that question. We're going to move to the next person with their hand raised. So Nona Miles, I see that your hand is raised, so I'm going to go ahead and unmute your line so you can ask your question.
Yes, hello. So I have a question going back to the PREV 12 measure with the standard operating procedure. Previously in 2019 and 2020, you had accepted if we had a standard operating process in place that scored, for example, a patient scoring 8 or less, we considered that as negative, and anyone 9 or above, we consider as positive if we have that as our standard process. That if we did not have documented as negative or positive in the chart, that would be acceptable to meet the requirement. So if it was a 9 or above, we would have a follow-up plan and that would be documented. However, anything that was 8 or less, of course, we're not going to have a follow-up plan documented in the chart, but it was given since that is our standard process. Is that still acceptable for 2021? Because it sounds like you were saying something different on the earlier question.
Hi, this is Katie from the PIMS team. I think as it relates to office policy, I think we would need to take a look at those a little bit closer and kind of review those questions on a case-by-case basis through the service center. So if you can, please send your question to qpp@cms.hhs.gov. And that's specifically related to, like office policies as it relates to interpreting the depression screening for PREV 12. And
Yes,
then in terms of, otherwise just in general measure guidance, I think the answer is still appropriate outside of an office policy. That clinician interpretation is required because there's other factors involved with the clinician interaction and the patient that would need to be taken into consideration. So again, please direct your policy question to qpp@cms.hhs.gov. Thank you.
Great, thanks for that response. We're now going to move on to the next person with their hand raised. So Sandra Stewart, I'm going to go ahead and unmute your line so that you can ask your question.
I'm all set. Thank you very much.
That sounds good. And we'll move on to our next person with their hand raised. So Laura Tidwell, I see that your hand is raised, and I will go ahead and unmute your line.
Hi, yes, I think my questions have been answered. I had the same thing about the clinic for PREV 12, where the clinic standards have a certain standard of what is positive and negative, and the physician has not documented whether it's positive or negative. It's sounding like we cannot go with our standard, we have to have physician documentation. That's the last question they asked that too. So do I need to send that in to PIMS?
So if it's related to a documented office policy, those are the types of questions that we would ask you submit to the service center.
Yeah, because the physician has in their note what the score is, but has not said if it's positive or negative. It's just assumed that it's positive because it's greater than 3, and that's in the standard as far as the PHQ-2 is concerned.
Okay, so yes, I would refer it back to the service center in regard to a documented policy that your clinic may be following. We would want to take a look at those and answer them through that avenue. Thank you.
Should we send in the policy too, or just reference it in the question?
I think that's up to you. Either way, it doesn't hurt. So if you want to go ahead and include that, I think it'd be fine.
Okay, thank you.
Great, thank you for your question. And it looks like we have one more person with their hand raised on the line. So Canna Howard, I'm going to go ahead and unmute your line so that you can ask your question.
Thank you very much. I just wanted to let you know regarding the Prev 12 question, you are going to be completely inundated with questions about this because this has been allowed in the past. I think the miscommunication we're having is that this is used primarily so that the physician doesn't need to individually address every negative outcome. Obviously, if there is a positive depression screening, the physician is going to interpret that, is going to discuss it with the patient, whatever is going to go on with the follow-up, etc. This is more of a guideline that's been put in place so that they don't have to actually document each of those as a negative outcome. It was something that has been allowed at least 2 years. So I just wanted to give you a heads up that you're going to get inundated with questions about this because it has been allowed, but just letting you know this, okay? Thank you very much for listening.
Great, thank you so much. And it looks like that is the last person on the line with their hand raised for now. So we're going to move back into our questions that have been submitted through the Q&A box. So our first question that's come in asks, is the documentation of physical therapy for patient fall risk assessment for arthritic knees?
Hey, this is Carol with the PIMS team. So for this measure, defining a screening for future fall risk as an assessment of whether an individual has experienced a fall or a problem with gait or balance. If the medical record supports that the patient was assessed for problems with gait or balance, then the intent of the measure has been met. And that's up to the physician's discretion as to determining what they consider as what is met for the screening. Thanks.
Great, thanks so much. And we have another question about CARE 2, the fall screening. And that question asks, if a patient has an encounter for a fall during the measurement period, would that be considered as the patient being screened?
Yep, so for medical record documentation, for all eligible patients, of an assessment of whether an individual has experienced a fall or a problem with gait or balance at least once during the measurement period, that would meet the intent of the measure. A specific screening tool is not required for this measure.
Great, thanks so much. And we have one more related question that asks, for the CARE 2 fall risk screening, if the provider evaluated the patient's gait and or balance, would that qualify for the numerator?
Yep. So, yep, defining screening for future fall risk. The measure defines it as whether an individual has experienced a fall or a problem with gait or balance. And the medical record just needs to support that.
Great, thank you for that clarification. We'll move on to our next question that has been submitted through the Q&A box. And this question asks, we have a patient that is 65 years old at the beginning of the measurement period that was not screened for breast cancer due to documented bedbound and unable to have screening. Can this patient be excluded from the measure? Due to her age, she does not meet the exclusion age. Could there be a CMS accepted exclusion?
Hi, this is Angie. You could file for a CMS other approved reason if you would like, if there are unique circumstances, etc. The measure itself, sorry, I'm trying to bring up the stuff here quickly. For Prep 5, I don't, yeah, there aren't any exceptions for patients that are not 66 years of age or older. So you are welcome to submit a CMS other approved reason request if you would like. Thank you.
Great, thank you. So our next question that is from the Q&A box asks, you have previously stated that claims information with the diagnosis will be needed to back up documentation. But if there is claims information for mammograms, colonoscopies, and flu shots which don't need diagnosis documentation, would these claims information be allowed without having us find backup documentation for them?
And this is Deb. No, that is not, you can't use claims for the PREV 5 mammogram or PREV 6 colonoscopy. The only time that you do not have to have medical record documentation is in the case where a PREV 7 has been pre-filled. If PREV 7 has been pre-filled, you do not have to look for additional documentation. But for any of the other cases, you do want to confirm that you have medical record documentation to support that the patient is denominator eligible for that particular measure. Thank you.
Great, thanks so much for that response. And then looking through our Q&A box, we have another question that has come in. And this question asks, for MH1, should the PHQ2 and PHQ9 be reported? We first screen the patient with the PHQ2. If positive, we screen with PHQ9, resulting in a total depression score. Is it correct to submit only the PHQ9 or the combined PHQ9 and PHQ2?
Hi, this is Angie. So for the MH1 measure, the only tools that are appropriate for the measure to indicate remission is a completed PHQ9 or a completed PHQ9M. And yes, there should be a valid summary score. Thank you.
Great, thanks so much. Our next question from the Q&A box asks, if patient notes that patient is walking good, would that meet the intent of falls risk for falls, gait, or balance?
Hi, this is Carol again. So medical record documentation, we'll just start with this, for all patients, an assessment of whether an individual has experienced a fall or a problem with gait or balance at least once during the measurement period would meet the intent of the measure. A specific tool is not required. However, due to kind of the individual nature of some of the questions related to documentation, we cannot provide specific feedback regarding whether or not documentation in the patient's medical record, including screenshots, would meet the intent of the measure or would suffice for a given measure in the event, just in case. So in those cases, you would have to determine if it meets, I guess, the documentation would meet an assessment of fall or a problem with gait. Thanks.
Great, thank you for that response. And we have one more question that's come in through our Q&A box, and that question asks, a patient has documented dense breasts and receives ultrasounds, not mammograms. Do we need to submit a CMS approved reason?
Hi, this is Angie. So ultrasounds are not considered breast cancer screening for the measure, and there are no denominator exclusions other than the over age 65. So if you feel that this is a unique situation and the patient could not receive a mammogram, then you could then submit a request for the CMS other approved reason. Thank you.
Great, thank you for that clarification. Our next question asks, for the exclusion of age 66 and older for frailty and advanced illness for the HTN measure, if a patient is wheelchair bound, which can be considered frailty, and has an advanced illness, can that patient be excluded for the QM? There is no note stating the patient is frail, only that they are immobile and confined to a wheelchair. Would this meet the intent of the HTN exclusion?
Hi, this is Angie. For these exclusions, you would need to refer to the coding document for the denominator exclusion codes for the measure, and that will give you all of the acceptable codes or descriptions of conditions that are acceptable for exclusions. And if it isn't on there, then it would not be considered included for the exclusion. Thanks.
Great, thank you. We have another question that has come into the Q&A box, and this question asks, does an encounter need to be signed to be considered legitimate evidence?
Hi, this is Jamie with PIMS team. This is in regards to the question at 104 or 204 from the documented dense breast question. And honestly, the encounter doesn't need to be signed. I think what the question is referencing is clinician sign off on the final report, and that, the report would have to be okayed by the clinician. So if that is not the answer that you're looking for and you need further clarity, please provide further detail within the chat or go ahead and submit a service center question as a follow-up. Thanks.
Great, thank you so much for that clarification. It looks like we don't have anyone on the line with their hands raised. So please, if you would like to ask a question live on the phone line, please raise your hand and we can go ahead and unmute you. So we will hold now for any final questions before we end the webinar this afternoon.
Hi, this is Katie from the PIMS team. So I did want to circle back to the MH1 discussion regarding the timing of the denominator exclusions. So just to kind of reiterate that the measure specifications do state that the diagnosis should be any time prior to the end of the measure assessment period. So going back to that guidance, we just need to ensure there's medical record documentation of an active diagnosis of bipolar personality disorder, schizophrenia, psychotic disorder, which is meaning that the diagnosis is either on the patient's problem list, a diagnosis code description listed on the encounter, or is documented in a progress note that the patient is being treated or managed for the disease or condition. So it is acceptable to have the diagnosis code on the encounter or problem list, or the diagnosis code written out on the progress note or problem list can be used to confirm the diagnosis. Additionally, in paper records, the description schizophrenia can be used with the option to confirm by billing code. Thank you.
Great, thank you so much for that clarification. And going back to the phone line, I don't see any folks with their hands raised. So we'll do one more check of the Q&A box to see if there are questions in there. But otherwise, we will just hold for another minute for any last minute questions to come in. And I do see that there is a hand raised. So Crystal Limoges, I see that your hand is raised. So I'll go ahead and unmute your line so that you can speak.
Hi there. Yes, this is in regards to the encounter. Does it need to be signed? That was in reference to annual wellness visits for like your patient reported things like colonoscopy and all of that. In the documentation, does the encounter have to be signed, or are we able to still submit it even though it isn't closed?
So Crystal, this is Jamie. Thanks for sending in that follow-up. We were actually scrambling looking at that acronym that you used, and once we figured it out, we are all like, oh yeah, that's what it is. I still think you need to submit your question to the service center just to be sure that we give you the right answer. As far as the encounter being signed off and the information that you receive from the patient during that particular visit, I just want to make sure that we have a clear understanding, and I don't know if we have the time to get into that detail with you on the phone call. So I'm not trying to put you off, but if you could please put in a service center ticket, I think we'll get the answer that you need. Does that seem amendable?
Absolutely. Okay. Yes, ma'am.
Okay, thank
you.
You're welcome. Bye-bye. Or thank you.
Great. Thank you so much for that response. And next, we're going to move on to another attendee with their hand raised. So Laura Tidwell, I'm going to go ahead and unmute your line so that you can ask your question.
Hi, so this is in reference to when they circled back about the MH1 question about the denominator exclusion. I understand your wording on that the denominator exclusion has to be prior to the end of the time period, but in other measures, and I can't say which one off the top of my head, it does say that these codes can be anytime prior to the measurement period. So it sounds like as long as it doesn't end or have discontinuation of it prior to the end of the measurement period, that any time prior to in the years before, even if we don't have it in the current 2021 year, if we have a denomination code, say in 2017, we can exclude that patient because they have had a history of whatever that denominator exclusion code was, psychosis or whatever. Am I understanding that correctly?
Hi, Laura. This is Angie again. So Katie and I are discussing this, and I know that I've been working with you on this question on your ServiceNow case. So
Yeah.
I'm going to reopen it and confer with the team and make sure that we're giving you the correct answer and then give it back to you in writing. I believe that's correct what you're saying, but I just want to check on a few things because I think we had this question in the past and we may have reached out to the measure owner for some clarification. So I'd like to kind of dig for that and discuss with my team and then let you know. Would that be all right?
That would be great. Thank you.
All right. Thanks. It is kind of confusing, so for all of us, but thanks for asking.
Yeah, it's just mainly about any time prior to the measurement period. I understand within the measurement period, but if it's prior to, that's my question. Thank you.
Okay. You're welcome.
Hi, this is Carol. There is a question by Sonia that I'd like to respond to. The question is regarding Care 2, if under the neural part of the physical assessment and the MD writes gait normal with this count. So medical record documentation of gait is normal would meet the intent of the measure and address that the patient has been screened. The use of assessment is not specific to the use of the screening tool, but may also include an assessment performed with or without the screening tool by the clinician. Thanks.
Thank you so much for that clarification. So now we are going to go to our question box and make sure that everyone has a chance to ask any of their questions before the end of the webinar. So we do have a question that's come in that asked, is the MH coding document for denominator exclusions considered all-inclusive?
Hi, this is Angie. Yes, it is. The condition would need to be on the denominator exclusion code tab on the coding document in order to qualify. Thank you.
Great. Thank you so much for that clarification. So with that, I see that there are no more attendees with their hands raised. And so I think we can go ahead and conclude the Q&A portion of the webinar this afternoon. So this does conclude the Q&A portion of the webinar, and I will turn it back over to Lisa Marie Gomez to conclude this call.
Thank you everyone for joining us today and posing your questions and allowing us to be able to address any of the questions that you did have. The slide deck for today, the recording and transcript from today's call will be available on the QPP webinar library in the next 2 weeks. As a reminder, our next support call is scheduled for Wednesday, February 23rd from 1 to 2:30 p.m. Eastern Time, during which we'll cover frequently asked measure questions regarding PREV 6, PREV 10, and PREV 13. We hope you'll join us. Thank you again, and this concludes today's support call.